Hello. So can someone please help switching off the phone line? Behind or where else? So good morning. I'm Herman again. Nice to meet you again in the morning. Okay. So today, better not to be really very fast. Okay. Also, you have a whole 2 days, 1.5 days course already. Until now, we will summing up together. We have many different modules, go through different regions and go through different areas, right? So we will go again, come back, or we calm down, go back, and think, okay? Because the ultrasound tool, most of the time we will say that we have as a visual stethoscope in our scope of practice for fundamental physician, okay? But whenever you have a new truth, you learn a new truth, you will need to know how to use it. So it's actually just like when you new soldier, okay, you learn a gun. You learn how to use a gun, but you don't know when to use a gun, okay? And what is the limitation, what is the danger of using a gun? It will be linked to you and to the patient, right? So as we are the emergency physician or critical care physician or frontline physician, whatever. We want to use it as a bedside tool, okay? So we always emphasize as some kind called a focus point of care ultrasound, the focus ultrasound rather than a very comprehensive ultrasound in the radiologist department. So what does that mean? That most of the time we have a very focused clinical question, just as Dr. told that, right? Okay, as a global protocol, something else. Okay, for example, will you pick up the poke when you see a patient with ventricular fibrillation? No, okay? Okay, that's the point, right? Patient got cardiac arrest. I just have the cause of WINFOCUS. So let's have the talk first, okay? This is another one of the problem. Another thing is that you see that, and yet, just like yesterday lecture, we are using the poke in the first trimester ultrasound, okay? Some of the young colleagues will come to me and ask me to have an ultrasound on the second trimester. Someone have 20-something age of gestation to have an ultrasound on it. I would say that most of the time it's out of our scope and out of our capacity, okay, especially for those who are newcomer, right? So beware, what is your clinical question and what are you going to answer, okay? So this is a very important point, one of the limitation of pitfall, okay? Going back to some technical and more practical things is that it's easy to classify. Okay, if there is any pitfall, any error, or any limitation coming out, you can have a patient factor, physician factor, and machine factor, so on, right? Okay, easy to understand. So again, as said, the scope of practice, organ, problem, specific, protocol-based, focus, skill. Most importantly, as said, okay, we want to ask yourself first, before picking up the poke on the patient, what are you looking at, okay? What will affect your management, if it's positive or negative? What if it is equivocal, okay? Most of the time, ultrasound protocol, at the end, there is an item, okay? It's equivocal finding, okay? It may not help your decision after your ultrasound, but you need to understand it, right? So on the very different protocol, that's why the WINFOCUS all the world, they are developing the protocol, how to guide you, have to develop guidelines and algorithm to help you what we can do, where we can have, what information we can have of different situations using the A to E protocol, the mnemonic, right? So different protocols, okay, this is the echocardiogram protocol. If you go to the WB course later, you find that we have the FATE, okay, so this focal assessment of the forest, transverse ultrasound. We have the field protocol. We want to incorporate, okay, the use of focused cardiac ultrasound during cardiac arrest. Do you think what? Can anyone answer me which type of cardiac arrest? The new ACRS protocol as actually launched recently, but not yet okay, I mean the incorporated focus ultrasound, right? Okay, only may have 1 to 2 centers. But what do you think of focused cardiac ultrasound during cardiac arrest? What specific situations do you think of? VF, as I mentioned, not VF, right? It's clearly stoppable rhythm, okay? It's not pulse, it's defibrillator, right? So what it actually is actually PEA, pulsed electrical activity. Most of the time it's most useful, okay? Including you can detect it pericardial tamina, right? Regional wall movement abnormality, right? Right ventricular ghostly dilated, you will think that massive PE, right? Because the pulse help you to differentiate where to go, where to help the patient immediately, right? But at the same time, we don't want to disturb the resuscitation of the patient. Okay, it's easy to understand. ACLS teachers, okay, compaction, 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 and compaction. Okay, right? Okay, always make cardiac output, right? So, blue protocol, right? 4 protocol, everything. We want to guide you in different situation use of the point of care ultrasound incorporated in the algorithm, okay? So, this one mentioned yesterday, right? Okay, pregnancy protocol. Actually, looking back, I think it's a little bit, it's not to say a little bit, it's much more complex than should be expected. Okay, so let's say ectopic or no ectopic, right? Okay. And we sent our recommendation on the lung and also the cardiac focus ultrasound, right? So, moreover, even another thing is that, okay, you need to know how accurate when you are putting the hook on it. Okay, just as an example in trauma situation. Okay, you know that it is much better on detecting free fluid. However, the fluid should be more than 200. Okay, under 200 ml of free fluid hematopoiesis, you may not detect it. Okay, okay. So most of the time, people will say that more than 500 ml of hematopoiesis you can detect it. Another thing is that you see that with solid organ injury, the sensitivity is just like tossing the coin. Okay, so you just make a guess, it's no different. It's 50% sensitivity only, right? Okay, so you know that you have major trauma patients suspected peritoneal, intraperitoneal organ injury. Okay, fast scan cannot rule out solid organ injury. Okay, or is another injury inside the abdomen may not be useful by the ultrasound, even by CT. What is surgeon sometimes, always in the literature in trauma situation, what significant intra-abdominal injury is a pitfall, can easily be missed, can do this, right? Kidney may not, CT scan most of the time can detect that. Right? Exactly, okay. Hollow viscous, okay. The bowel, okay, right. If you have a little bit of ruptured bowel, okay, even you may not detect gas, okay. But bowel, hollow viscous injury is one of the major pitfalls in the intra-abdominal injury. So most classical is sometimes with sick bowel injury, okay. So if a patient has a spine injury or something like a transfracture, you think of it, you still remember, right? Okay, let's go on, okay. So, going back to some technical issue, right? Okay, patient fracture, poke fracture, clinical fracture, machine fracture, right? You will be scared, okay? You will step back when you face this patient. We want to pick up the poke, okay? You have a fat, many fat on the tummy, many fat on the chest, short neck, okay, very many fat on the neck, okay. This is enemy to ultrasound. And actually, it is an enemy to physician, right? Okay, so when you have an agitated patient, this is a classical diagram for serotonin syndrome, if you still remember, right? So agitated, dilated pupil, freaking around, sweaty, right? You will never have a resting patient for you to have a poke on it, right? So with a severe trauma, even some surgical emphysema, air on the subcutaneous tissue, okay, ghostly dilated bowel, okay, obscuring the things behind, the solid organ. Another thing, okay. So what do you think, what do you see? What do you see on this one? Anyone can help? Make it a little bit interactive, right? So anyone can help? So what is it now? Let's say maybe, okay, so forget about the marking. What organ is it? What region is it? I haven't got a marker on it, but hopefully you may identify something, right? What is it? Yes, right, uterus, okay. This is the urinary bladder, okay. It is the urinary bladder, a small urinary bladder. This is the sagittal section, okay. So the uterus is quite large now, but what is the abnormality? Yes, Hydrophthiscus. Okay, there's hypotense aqueous fluid inside. Is it abnormal?
Yes.
Okay. To answer your question, yes or no? Okay, so this is the point. Okay, it detects something seems to be abnormal. But usually at the same time, you need to incorporate in the clinical situation and also the ultrasound finding. Because pouch of ductus fluid most of the time is physiological, right? And people will say that to the fundus of the uterus, basically absolutely abnormal, okay? And if it's passed through the cervix, can be or cannot be, right? But to this amount of fluid, I will treat it as abnormal until proven otherwise, right? It's so thick, okay? Usually it's a thin rim or free fluid here, right? So this illustrates point of care ultrasound, just like maybe some of the clinical tests you have, okay? If you have a deranged liver function, okay, a little bit can be very abnormal or just physiological, may not physiological, may just viral, whatever. Just like point of care test, you need to add up and interpret it with together as a clinical situation and try to see which way you go. May not be the yes or no way, maybe the middle part, but better off you take it as a more serious way, a safer way, right? So, Pope, whether you choose a curvilinear, you choose a transvaginal, you don't know how to use it, there's a very complex panel, okay, many buttons on it, so you need to be familiar, and it is very operator dependent, right? Okay, you need experience, you need to play, okay? Or high different end of machine, okay? When to use it, okay, for us, if you this big machine, you will have headache, okay? Especially we are using point of care basic ultrasound. Most of the time we will use the middle end or even the front end, right? Okay, the handheld device. But handheld device, the resolution may not be so good, right? So some pitfall cases, again, right? So just like the cases as Dr. Toh said, and sometimes we encounter something vocal and some of the common pitfall we may encounter, right? So 32 years old, good past health, sexually active, low abdominal pain for weeks. Increase it today. BP stretch like that, a little bit tachycardic. So what do you think of? Okay, most of the time we like to think of important, essential, emergency, urgent, defensive diagnosis. Okay. So what is the professional thing or the emergency thing you need to think of and rule out first? Atopic, right? Okay, so is it good enough? Okay, we can give a PT test if PT test positive or even negative because our window period go for a perfect ultrasound. We want to look for IUP, right? So anyone can help, okay? So what do you see here and here? Right, this is the same diagram. And how about, actually it's the same patient. With this fluid, I say yes or no. With this, you say yes or no. I mean, what we say? Is it abnormal? Normal. Comfort, okay? Abnormal. Should feel fluid in the Morrison pouch. However, how abnormal? What can it be? Okay, and one thing is quantitative, but I'm not asking that. What can it be? I just say free fluid intraperitoneal, you say? So what can it be? Can be fluid. Okay. can be hemoperitoneum, but can be just excited, reactive fluid, whatever. Ultrasound, most of the time can tell you this is free fluid only, right? Okay, so go on again. This is a real case. And this is an ultrasound. Okay, I have the answer for you. So when I look into the abdomen, this is a huge intra-abdominal mass, okay, which is capsulated. You see the capsule, right? And then there are multiple attenuation from the mass. You see multiple attenuation, acoustic straddling, okay? And also there is some solid sits inside, right? Okay, so together, X-ray. And okay, I don't have a gift, but I give you some pause if you answer this question, right? Okay, so what is this? What is this? I have the answer for you. It should be easier for you. Teeth. Okay, this is not a window stone in a window. I can identify the window. The thing is that if you see this mass over the white norm, it can be a window mass actually, right? Okay, with stone. But I can identify a normal white kidney. Okay? So it's less unlikely to be a white kidney mass or problem. Okay? Actually this is a tooth. And this case is a mature teratoma, abdominal mass. The fluid inside probably some reactive fluid. After going into the hospital, the gynecologist won't go wash in and open up. They don't find any hematopoiesis. Okay? So they just plan the operation. So this is CT scan of the corresponding to multiple cystic lesion, right? How many times do you have? So second case, very upper quadrant vein, good parcel, 56 years old. Okay, jaundice. Okay, so about this is not so alarming, but I will say that if you measure it up, if I told you it's around 9 mm, just for example, I told you that, no, this is just around 5 mm, 5 mm. With this section, do you think it's normal? This is the section, you have the gallbladder lateral vein, right? So this is the hepatobiliary scandibiliary sheet. Okay, you have the portal ring here, okay? And then you have tubular structure above it. Okay, you think it's a CBD, and you measure it, and then you find that it's only 5 mm. Is 5 mm normal? 5 mm is normal. Okay, and again, okay, this is actually pitfall. What does this diagram illustrate? What do you think I want to illustrate? This is another pitfall, right? Yeah. So, Mickey Mouse. Right ear, left ear. Right ear is what? Exactly. What is right ear? CBD. What is left ear? Yes, common hepatic artery. Right? So, if you cut the section here, you think it is a normal CBD. This is one of the biggest pitfalls in the hepatobiliary system, right? So someone will say that if you see the end-on view of the right hepatic artery here, you assume this is the CBD, right? But ultrasound is dynamic. You always do it in two sections, I say because as you just see this picture, you don't know this, for example, you don't know this is a tubular structure or a sphere structure, okay? And every time do it in two sections, right? Perpendicular. And you have many gallbladder stone causing acoustic straddling inside the gallbladder, okay? So, dyspnea man, COPD, white pneumo, okay? This one. What's the problem? Put a needle in. So anyone, what's the problem? Yeah, okay, no sliding, right? Okay? And, but Luca always like to say that HSC is Luca's image, right? Okay, so what is it? Pulse, okay. It's a lung pulse, you see lung pulse? Okay, just like that. Okay? What does it mean? If there's absence of sliding, the lung can be not here, okay? The lung pulse indicates that the lung is here, right? Okay. lung pulse is not the pulse of the lung, it's a transmitted pulse from the cardiac, from the heart, okay? Pop, pop, pop. So you know that the lung is here, but absent of sliding. Or is it mean this pleural problem, okay? So, artery, but if you think that is a pneumothorax, you put a needle in, okay? So, this is actually a right pool disease, okay? So how about this one? Exactly, right. So what is the, how signifying, how good is a lung point? Okay, basically we call it pathologic for white pneumothorax, right? Okay, so sliding here, no sliding here. So another man, dyspnea, there is hypotensive, creatinine around 300, JUP elevated. Okay, I think TOE has many of this kind of sign. So you put a needle in, you're not well seeing the RV in this section. You see the LV is moving, okay, although not quite good, right? Okay, so you see some fluid around the heart. So what do you think? Pleural, pericardial. Yes, but which one? Which one? Pericardial or pleural? Yeah. So this is one of the points. Exactly. You see, what is it? This is right. This is parasyndolonesics. Behind it is a descending aorta. The fluid doesn't go through, go anterior. This go posterior. And actually something flipping around here. This is one of the lung, right? So this is a pleural effusion, right? Okay, so remember that. Pleural effusion, right? Lady, left leg swell, case one, almost done, right? So you see that. This is the left popliteal wing. Comfortable? Everything very comfortable, right? Okay. Discharge your patient? Okay, let's see. So this is the lecture of Pitfalls. So this is the left common femoral. What is so? Doppler is not the mandatory skill, so-called in the convection ultrasound, but you need to remember one of the pitfalls. Compatibility can be compatible, non-compatible, or in the middle is, what do you say, partly compatible. So what can you see here? Obviously, you see the pulse, right? So this is femoral artery. How about this? Femoral vein. Any abnormality? Thrombus, exactly. So you see that the Doppler flow is only one part of it, and here is a thrombus. Okay, so you may have a compressible popliteal vein. However, there is partial obstruction of thrombus. Actually, it's a case of DVT, right? Okay. Pregnant lady, this one I think you have seen. I don't go in very deeply. So uterus, okay, seems to be a satellite structure intrauterine, sagittal section, but as described it yesterday, it don't look like a fetus, a baby, right? Okay, you may call it substance, some substance inside. Okay, can be product of gestation but abnormal, but however can be also other thing is molar tendency, right? Okay, so you go to the sagittal section, you go to the coronal section, you find an asset. Okay, so this is a heterotopic pregnancy. So in summary, right, focused point of care. Don't use the poke and replace your clinical skill and other tests, right? The clinical application, patient, physician, and machine factor. Get familiar with your machine. Okay, whenever you have the workshop, if there is different machine, we will go earlier to get familiar with that. Okay, because the buttons, the titration is all different, right? So physician, get practice. Patient, hopefully have different windows in different situations, maybe ready sedation for the patient, right? Okay, so this end up my lecture here, right? Okay, thank you.